chiropractor, Dr. Gregory Johnson, and today we want to welcome Jeff all the way from northern Pennsylvania up next to the New York border. He has looked far and wide since August of 2013 because he was diagnosed with a hiatal hernia from his primary care doc, who sent him off to a gastroenterologist who also did a upper GI scope on him and found that he had a sliding hiatal hernia. So far, he hasn't been able to get any relief from the medication and procedures that they've offered him. So he decided that he was going to fly to Houston to Advanced Chiropractic Relief and see what we could do for him. So I'm going to show you what we're going to do. Okay, Jeff, let's stand right here and evaluate your posture first. All right, now, let's have you close your eyes and flex your head forward all the way, and backward all the way, and neutral. Now, those of you that have been watching my videos know that I evaluate posture like this on every single patient on an x-axis, the y-axis, and the z-axis. And we determine from that the biomechanical improprieties or misalignments globally from the head, neck, thoracic spine, lumbar spine, all the way down to the pelvis. One of the common characteristics that we see in a lot of hiatal hernia patients is that they have a forward head posture that increases the weight-bearing compressive stresses all the way down into this thoracolumbar spine region, which that's where the lower rib cage attaches. That's what strengthens or causes the diaphragm to become weak. If it's in alignment, it strengthens it up. If it's out of alignment, it becomes weak. The diaphragm allows the stomach to slip up through the opening into the esophagus, secrete acid into the esophagus, and that causes all kinds of havoc. So, okay, that's good. I got your posture, so let's come over here on this table. Now, we have not started to decompress him yet. This morning was his first treatment. He just got in from Philadelphia airport this morning, and we're treating him twice a day because he's going to be here for a short amount of time, so we're going to get the most that we can get done in that short period of time. That tightened up a little bit when I brought your legs up, huh? Yeah. So see, we still evaluate the patient's biomechanics all the way from the feet up into the pelvis, and we first start off with the sacroiliac joints and then the sacrum in the center. Then we get L5 in the Z plane, L4, L3, which also supplies the colon, L2, L1, and then I'm doing some lateral and oblique stretches on his paraspinal musculature from his sacrum all the way up into his upper thoracic spine. And he's very hypertonic, we found out this morning, which is an increase in the muscle tonus. It's not a spasm per se, but it's pretty tender right through there still, isn't it?
Yes, it is.
So what we did is we really identified these areas. And then those of you who have watched this before know that I used the Terminator to get these out of there. You can actually see on the patient when I get through the areas that are sore, that's dancing, tightens up. Like over here on this side, it's really bad right there. Again, all this hyperactivity is coming right around his thoracolumbar spine. This is where his mid-back vertebra meets his low back. And that again is the attachment for the diaphragm. Now I don't just stop with the Terminator, that's kind of my human meat tenderizer. I actually get my elbow right down in there and I slide up the muscles slowly, paraspinal, and he can really tell you how sore those guys are. Yeah, just have the patient breathing deeply as possible and trying to get through it here at first. Because you have to understand that what we're trying to do, we're not treating his hiatal hernia disease. We are treating the underlying reason that he has a hiatal hernia, which is subluxation of the vertebra in the lower thoracic upper lumbar spine that changes the entire alignment of his rib cage and the diaphragm itself. Go ahead and scoot up in there just a little bit more, Jeff. There we go. And then I'm also going to, okay, let this go. Perfect. There we go. I'm sure you heard those all the way over there. Very good. Let's go ahead and turn you on your back now, Jeff. Okay. Now this is an interesting thing here. I've got my thumbs and my hands right over his rib cage, and you can see that the left side of his rib cage is much higher than the right side. Do you see that? Here's the end of his sternum, which is called the xiphoid process. You don't want to get on that because that's a very painful thing if you get on that and break that. But look how much higher the left side of his rib cage is than the right side. So I find the xiphoid process right there. I'm right down below that. Have the patient take a deep breath in, Jeff. Let it all out. Then I go straight down into it. I find the top of the stomach called the fundus. I then pull that straight superior to inferior in the y-axis. Okay, let's try that again. Now, when I first start doing this is can be very painful because it's basically that stomach's all knotted up right underneath of the diaphragm. And even up above the diaphragm into the esophagus. So, yeah, we do this 3 times in a row. There we go. I can even feel the pulse now. Now, I also work on his colon by just doing some clockwise rotational moves over here in the ileocecal valve, and then over here in the descending colon where it turns in and has a valve between the lower colon and the rectum, so that we can get his tummy, I call it tummy, that's kind of a lay word for the gastrointestinal system made up of the small intestine, large intestine, and rectum. And now one more deep breath. I'm going to see if I can't get that down a little bit more. There we go. That's the deepest I've gotten on him so far. Now, you notice that I get on what a lot of people call the IT band. It's really the tensor fasciae lata, and I do transverse friction on that. And that's pretty tender, isn't it? I mean, anybody that's ever had this done on them can tell that these things here are very, very tender on anybody that has any kind of GI problems, because these muscles are neurologically connected to the colon. It's called somatovisceral. And see, I check his leg length now, and that's good and even. So I'm going to take his leg here, relax that knee. There we go. Good. I'm adjusting his knee all the way up into his pelvis. Did you feel that all the way up in your pelvis and low back? Okay. There, perfect. Good job. So again, like I said, we're not treating his hiatal hernia. We're treating why he has a hiatal hernia, the underlying cause. So let's set you up sideways here, Jeff. Remember, there we go. Good. So, Jeff, would you mind telling our YouTube viewers how you found us and how you came to be here in Houston today?
Yeah, as I mentioned before, after being diagnosed with a hiatal hernia from the medical community back in August of 2013, they provided no hope for me. They said I basically just had to live with it, take my medications, which I couldn't take because I became sick.
That made you even more ill, right?
Made me even worse. And so I started to do some research online and found that chiropractic care can help. But after contacting and visiting many chiropractors from my local area, I was unable to find any help. And I continued to do research online and found the website of Dr. Johnson along with his YouTube videos. And I contacted Dr. Johnson and Renee and talked to them on several occasions. And it quickly became apparent that he had the knowledge that I needed so he could try to heal me and make me feel better. And it became very quickly apparent that I needed to book a flight to Houston and come down and receive treatment from Dr. Johnson.
Good. So has it been worth it so far?
Yes, it has.
All right,
very
wonderful. And welcome to Houston. And
Thank
we're going to send him back to Pennsylvania without a hiatal hernia. And we're very happy to have you here, and thank you for telling everybody that.
Thank you.
This is your Houston chiropractor. We'll see you next time.